Now, from the News Channel 5 network, this is Medical Mondays.
Good evening, everyone. Thank you so much for being with us here on this Monday evening for Medical Mondays. I'm Carrie Sharp. A very important topic that I'm so happy to bring to women in particular tonight, and I'm glad you're joining us. And it's also your chance to call in and speak with us and speak to a doctor tonight. Ask any question you would like. I have Dr. Nancy Peacock from the Tennessee Oncology Group. Thank you for being here.
Sure, thanks for having me.
We are talking breast cancer, and there are so many questions and new research and new treatments to talk about that I just can't wait to dig in and get started. And we have a whole hour to go through everything. So again, if you have a question when it comes to breast cancer, whether it be how to test, what do you do once you have that diagnosis, what treatments are out there, what clinical trials are going on right now, go ahead and give us a call. The number's on the screen, 615-737+. As we get calls lined up, I'm going to ask Dr. Peacock a few questions, and I want to start with when it comes to self-exams and mammograms. There have been so many different guidelines out there, and really it just gets confusing because they're all contradictory about what you should do and when you should do it and how often you should do it. So what do you say?
Right. Well, that's a great question. One of the reasons that there are so many recommendations and so many fits and starts and changes to what the recommendations have been is because it remains controversial and we don't necessarily have the one right answer. I think that when it comes to self-exam, the American Cancer Society has said to tell doctors to tell their patients not to do that. It's not going to cause any harm, but they have not demonstrated a clear-cut benefit in self-exam in terms of improving diagnosis rates. So they said it doesn't work, don't do it. My opinion on that is that a woman knows her own breast better than anybody else, and she may not diagnose a woman may not diagnose every breast cancer that there is to be found, but she'll know if something's wrong many times. And so I think it's still a worthwhile exercise to do once a month. The other thing about mammography is even more difficult because ever since mammography came out in the 80s, there have been questions whether or not it's sensitive enough. Does it pick up all the breast cancers, whether or not it's specific enough? Does it see something on a mammogram and is it really cancer or is it something benign? And really, does it cost too much to society to screen women in all age groups? So for a lot of years, the recommendations were to start at 40 and then go up until about age 75. There's been no benefit to screening mammography after age 75, at least proven in terms of risk of death. So anyway, the Institute of Medicine had looked at thousands and thousands of women who had been examined and said, you know, we are not seeing enough sensitive pickups on our youngest patients. So we don't think you should start mammographic screening until age 50. Not because you won't pick up some cancers in young women, but because it's not a good enough screening test in our younger patients. It has to do with the composition of women's breast and how much fat to how much glandular tissue there is. So there's a lot that goes into those blanket statements. But if there's a woman who's at high risk, then start screening early. And there are several things that can cause high risk, but you start screening early at age 40 or 45 and you continue on.
Let's go through those high risks. What would that be?
So for families who have a known genetic mutation that increases their risk, we typically call that a BRCA mutation. Those are most commonly associated with a high risk of breast cancer in women, usually before the age of 40, also an increased risk of ovarian cancer. That's a topic for another time. There are some other mutations that are starting to be noticed as increasing women's risk for breast cancer, and yet we don't know how much those mutations increase her risk. So we don't necessarily tell women that they need to be screened early if they have those mutations, and yet we do it anyway. If you have a strong family history with no known genetic mutation, we also recommend screening early. There are some women who've had, and this is not very many, but Hodgkin's disease when they were young and had radiation to their neck and chest. That's a group of patients that are at high risk for breast cancer, and we recommend early screening for them.
Let's talk about that genetic risk. Again, in the news, you often hear about the BRCA gene. And if your mom has had breast cancer, your aunt, your sister, do you recommend that women just go ahead and get the test, and that way you know one way or the other?
Well, it's a little bit complex because the testing is expensive. You know, if you think about testing a woman her entire genome, it costs about $5,000. Insurance companies are not likely to pay for it without good reason. So if you have a strong family history and someone with a known mutation, your mom, your aunt, your grandmother, or even on your dad's side, let's say your dad had breast cancer, or your dad's sister had breast cancer, or his mother had breast cancer, and they have a known mutation, then testing is important. And we do tell people, we don't just have a blanket statement that we test everyone, although testing guidelines have gotten a little bit looser lately. But you have to remember that only at the outside 10% of all women who have breast cancer have a BRCA mutation or a BRCA mutation. So it's not by any means the majority of women who have breast cancer.
I had never heard that, so that's interesting.
Yeah.
Very small percentage there.
Right.
When it comes to treating breast cancer, once a woman gets that diagnosis, and clearly that is a terrible, terrible day, where do you go from there? When I come see you and say, okay, I've got breast cancer,
Yeah.
what happens then?
So typically by the time I see someone, they've already had a biopsy. That's usually been really organized by their primary care doctor, their gynecologist, the breast radiologist who saw them with an abnormal mammogram. And so I have a little bit of information when they come in. Many times the breast surgeons have already examined the patients, may have already done the operative procedure that the woman needs. One thing that's changed a lot in the last 10 years is that many times, especially in certain high-risk breast cancers, we're giving chemotherapy or systemic therapy before they have their surgery. Again, every woman's a little bit different, but for women who have either a high-risk triple-negative breast cancer, a very aggressive triple-negative breast cancer, or women who have a HER2-positive breast cancer, we'll often treat them before they have their surgery for a lot of different reasons, but we'll start there first. Those women usually require a lot of treatment, and so we do some preliminary testing. Not every woman will get staging, CT scans of the chest, the abdomen, the pelvis. Not everyone needs it, but if she has a big tumor or if she has a lot of positive nodes, then we need to screen them before we start their treatment to make sure their cancer hasn't already spread outside their breast. Most of the time it hasn't, but again, those are all things that we sort of individualize for each patient, because like you mentioned just a minute ago, you don't know where to go. You think,
Yeah.
oh my gosh, I have cancer, and the normal human nature thing to do is go, cancer, die. I've got cancer, I'm going to die, which is not so much true anymore. We can't cure everybody, but we cure a lot of patients now.
What are the survival rates when it comes to breast cancer now?
Yeah, we think that, again, depending on the type of cancer it is, and these markers I keep talking about, triple negative or ER/PR positive, HER2 positive, it just sort of depends. But survival rates can be as high as 80% in the endocrine sensitive breast cancers. They may be as low as 20 or 30% though in the very aggressive triple negative breast cancers.
And one thing we were talking about before we started here, oftentimes, but not all the time, but oftentimes younger women have the more aggressive forms of breast cancer.
Right, right, and I think they take a really special approach. I think there's a lot of research being done to try and find the most optimal treatments for those women. Right now we have good treatments, but they're not good enough. And until we have better drugs in the earlier stages of these triple negative breast cancers to treat these women, we're not going to see our survival rates start to improve. But there is a lot of work being done, a lot of new ideas being thrown out.
And that's what I want to talk to you about next. What is on the horizon when it comes to breast cancer treatment? So we're going to take a quick break. Again, if you have a phone call, go ahead and give us a ring. The number's right there on the bottom of the screen, 615-737+. We would love to hear from you tonight. It is your chance to ask Dr. Peacock what is ever on your mind when it comes to breast cancer. So we will be right back.